Hi, my name is Kristen Parkins. I am a physical therapist at Roper Downtown, and this presentation was created by Ellen Clemens, the rehab manager at Berkeley, Hannah Pendergrass, a physical therapist at St. Francis, and myself. And the purpose of this presentation is to provide you with the education and tools and confidence to be able to safely mobilize your patients in the hospital setting. Each discipline within the hospital setting has their own unique role within patient care. But when we consider the overarching team goals, there are several that stand out. Most importantly would be safety. So we must keep every patient safe, and to do that, we have to keep ourselves safe. We also need to prevent any hospital-acquired complications. That would include skin breakdown, blood clots, pneumonia, deconditioning, falls, delirium, and others. And lastly, we would like to improve the positive patient outcomes. So we want to decrease length of stay, decrease risk for readmission, optimize the patient experience, and then ensure a safe discharge home. And what the evidence shows is that mobility is the clinical tool that ties all of these outcomes together. One of the biggest misconceptions that we run into within the hospital is everyone's understanding of whose role it is to mobilize patients. So we felt that would be important to talk about. And the answer is actually all of us. Just to give a few examples, if you look around, you'll see the transport team mobilizing patients, you'll see nursing staff, you'll see PCTs, and then certainly therapy, just to name a few. But it's important for all of us to know our role so that, again, we can address and really optimize all of those outcomes that I mentioned on the slide prior. Before we jump into the strategies behind safe patient mobilization, we want to acknowledge the common barriers that are faced on a daily basis. Those include operational realities like time limitations, especially those related to the new staffing ratios and staffing challenges. It also includes interruptions when patients are taken off of the floor for tests or procedures, all of which take away time that we are able to mobilize. We also consider patient-related challenges when patients are having too much pain or they're too tired. They may have a fear of mobility, or they may just flat out refuse. And other patients are truly medically unstable. And finally, we have to consider gaps within the system. As a therapist, we hear frequently that staff members do not feel confident utilizing lift equipment throughout the hospital. There may also be an uncertainty of whose role it is to mobilize the patient or whether or not the patient is appropriate to mobilize, and certainly a fear of a patient-related injury or a staff-related injury. What we want you to know is that our goal is not to eliminate these barriers, but we do hope to control what we're able to, and we want to focus and manage them safely and consistently. The first step in preparing your patient for safe mobility includes having a full understanding of their clinical picture. This includes assessing their activity restrictions. That would include the activity order, the patient's weight-bearing status, the presence of wounds, and understanding if specific bracing and orthotics are needed. There are also functional considerations. We need to ask baseline mobility status. We need to understand if there are any acute neurological changes. We would like to ask if there is a history of falls, and we would also need to know their current cognitive status. And finally, we need to know if the patient is currently medically stable, and we do that by assessing lines, drains, and tubes. We need to know if there are any abnormal or critical labs that would impact mobility in a negative way, and we also need to ensure stability of their vital signs. After the completion of this training, there will be hands-on training where we discuss very specific examples and patient cases to work through all of these assessments. What we want you to know is that it's important to consider every portion of the clinical picture, and if you're unsure, please pause and escalate to the charge nurse, another staff member, or therapy. Now that you have a full understanding of their clinical picture and the patient has been cleared to mobilize, you now need to set up your environment and all safety measures. So for the environment, you need to clear pathways and all trip hazards. You need to secure the cords, lines, and tubing and make sure they're in a position where you can monitor closely and they're on the side the patient is moving towards. And you also need to position and lock the destination surface. On the right, you'll see the recliner, and the recliner is equipped with a chair alarm connected to the blue box. There's also a sheet, a waffle cushion, and a tuck pad. And we will go over this in in-person training as well. We also need to consider our own safety. So for that, you can consider the bed height to ensure safe body mechanics. And you also need to gather all appropriate equipment, including a gait belt, lift equipment, walkers, etc., and appropriate assistance. So if you're anticipating needing 2 people, make sure you go into the room with 2 people. And then just before you move, we want you to confirm mobility one more time. You can double check how much assistance they've needed either in the hospital or at home if you're the first person moving them. We want to make sure we're assessing for possible dizziness or orthostatic risk. Taking a blood pressure before they move is never a bad idea. That way we can capture changes if it's needed and report them to the physician. And then we need to, again, review the lines, drains, oxygen, making sure that everything is portable if needed. And we need to apply non-skid socks to every patient and ask for help early if indicated. The biggest reminder here is if none of this has been completed or it's not fully completed and the destination is not ready or prepared, do not start the transfer. At this time, you would have a full understanding of the patient's clinical picture and room setup would be completed. Now it's time to choose the appropriate mobility device or piece of lift equipment. Things to consider are the patient's baseline mobility level and the equipment they use at home. Also, if they've been in the hospital, you can ask other staff members what devices have been utilized. The first piece of equipment is a walker, and it is utilized for patients who can stand and ambulate with supervision or minimal assistance. These patients are able to perform a majority of the work with the movement. It is used for patients with mild instability, weight-bearing precautions, and lower extremity weakness in standing. We use walkers for standing activities. Think about brushing their teeth at the sink or washing their hands. Also for transfers or ambulation. And to set it up at the proper height, when the patient is in standing, you would instruct them to relax their arms at their side, and the walker handles should hit just at their wrist height. If it is not at the correct height, you would instruct the patient to sit down safely. Then you would perform the adjustments, and then the patient would stand again to do whatever mobility is planned. We also recommend utilizing a gait belt if it is available to you on your unit, and staff should remain at the patient's side at all times. The next device provides an additional layer of support to patients. It is called the sit-to-stand device, and one brand commonly seen in our system is the Serasteti, which is pictured to the right. This is a device used for patients who are cleared to weight bear through both feet. They are able to stand with assistance, but once they're in stance, they would be too unsteady or unable to safely march in place or initiate steps. We can use this for patients who are looking to progress to standing and they are just needing that extra support. We can also use this for patients who need a safer way to get from point A to point B. So for transfers from the bed to the chair or recliner and the commode, for example. It does require the patient to follow commands, especially because most patients have not been exposed to this type of device. And additionally, it requires active participation. So if you are heave-hoing a patient, this is not the device to be used. And just a reminder, it is not appropriate for patients who are non-weight bearing or if they are unable to follow commands. The final piece of lift equipment and the most supportive is the dependent mechanical lift. This is for patients who are non-weight bearing, they are unable to stand safely, and they require a fully dependent transfer. Things to remember, this will require a minimum of 2 trained staff members. Before you even consider this transfer, you would need to assess the lift for proper functioning, so making sure that all of the controls are working appropriately and the battery has been fully charged. You also want to verify the sling type and size. And once the patient is in the sling and the sling is attached to the dependent lift, you want to confirm a secure attachment. Once you have completed the transfer, you need to plug in and recharge the lift so that it can be used for your patient and additional patients on the unit. Now I would like to review safe body mechanics. So if you mobilize a patient, please maintain a wide base of support. We want you to use an athletic stance, which means bending at your hips and knees so that you avoid rounding your back. We recommend that you keep the patient close to your body. Typically, the further away the patient is from you, the greater the risk for injury. We also recommend using leverage from your whole body and not just using a single arm or both arms. And then one of the biggest things you can do is encourage the patient to participate. So if you go in a room and plan to assist a patient with mobility, cue them to start the movement and only jump in if they need it. I also want to encourage you to have enough assistance with you. You can do that by anticipating it ahead of time, or if you find yourself in a bind, please stop trying to help the patient and call for enough hands to make sure it's safe. And the final piece here is considering the bed position. So if you're doing bed mobility, you can utilize the Trendelenburg position, and we always want to encourage the correct bed height to promote safe body mechanics. The final reminder here is that if it feels unsafe, it probably is. So please trust your gut. In those moments, we want you to pause and reassess. If there is a safe solution, then go for that. But if there is not, please stop and escalate further. Now completed all of the discussion regarding the safe preparation for mobility and things to consider. And now we're going to get into the mobility. So mobility is not an all or nothing process. We want you to know that each step prepares you and the patient for the next step. So within the hospital, rolling is the first step. If the patient is able to roll, we would progress them to sitting at the edge of the bed. If the patient can sit well with no adverse side effects, their vitals are stable, and they are not losing their balance, then we would want to progress them to standing. Same thing here. The patient is standing and they have no adverse events, their vitals are stable, and they are maintaining balance. We could consider marching in place and weight shifting to make sure they're safe to move, and then we would progress to a transfer. If they can transfer and they remain asymptomatic, it is likely appropriate to progress to walking. So the biggest thing to know about this continuum is that we want to use it to help advance patients to the highest safe level every single shift. The first level of mobility is rolling. The goal of rolling is to have the patient safely turn from their back to their side. You would do so by cueing them to bend their knees toward the rolling direction, and they would then use their arms to reach across their body for momentum, using a bed rail if it's appropriate. The staff member would assist at the patient's hips and shoulders, not on their arms. We never pull on the patient's arms, and that is to protect their shoulder joints. If that looks safe, we would then progress to sitting at the edge of the bed. So the patient is inside lying. The next step is having them kick their legs off the edge of the bed. Some patients do require assistance with this step. We would then cue them to push through their elbow and arms and hands up into the upright position. Again, some patients require significant assistance for this step. If they do, you can utilize the bed controls to lift the head of the bed to support the patient and assist your efforts. Once the patient is safely assisted to a seated position at the edge of the bed, we need to assess for changes in symptoms, changes in vitals, and their balance. If all of that appears stable, we would consider transitioning to standing. But before we do so, we need to double check a few things. So step one would be double checking to make sure that we previously did lock the bed in the chair. And this would be the time to apply a gait belt if you have one available to you. One thing to note is that if patients present with an abdominal incision or wounds or an ostomy or drains, we would just need to be cautious with where we place the gait belt to ensure safety. Now the patient is ready to transition to standing. So step one would be having the patient scoot towards the edge of the bed. Some patients do require assistance with this. It's important to note that if you did elevate the head of the bed, the knees may have also elevated, and you may need to drop the knees to a flat position so the patients have a better foundation. You want to make sure their knees are at or slightly below their hip height. If you need to utilize the bed controls, that can be a great way to achieve that, especially for tall people. Then you would cue them to lean forward. We like to use the cue nose over toes. And as they are leaning forward, the patients would push up from the bed. You will notice a lot of the patients attempt to pull from the walker, and that is not safe or correct. We really need to remind and sometimes physically assist their hands to the correct position to maintain safety. And then once they get up into a standing position, we're cueing them to really extend their hips and stand tall with their head upright. And they would be slowly transitioning one hand at a time to their walker. We do want to make sure they are fully upright and balanced before we consider progressing to the next step. If the patient is in stance, we need to assess their stability and balance before proceeding to the next level of mobility. Here, we want to make sure they're having no change in symptoms, no change in vitals, and that they're maintaining their balance. We do that by having them weight shift side to side and march in place. They are allowed to use a walker at this time, and if they have stability through all of these phases, they would be cleared to progress to the next level of mobility, which I will discuss next. If the patient is unstable, meaning they are unable to maintain their balance in standing, they are unable to march or weight shift, or they show changes in symptoms or vitals, we would have them sit down to reassess. These patients would not be appropriate to utilize a walker to transfer out of bed and would require a higher level of support, like the sit-to-stand device or dependent lift. So again, if a patient is requiring a lot of assistance to try to stand or cannot march in place, you do not attempt mobility with the walker alone. At that point, you would use the sit-to-stand device or a dependent lift as indicated. For the patients who are stable in standing and they are able to march with no change in vitals or symptoms, they will progress to a stand pivot transfer. Now, the setup for this transfer will be completed before you even start mobility, and this includes positioning the chair next to the bed and locking the wheels of the bed and the chair. Now, the patient is in standing, and to complete the transfer, you will cue them to take small and controlled steps towards the destination. You will also cue them to stay within the walker frame and have tall posture. If a gait belt is available, you would be maintaining your hand on the gait belt for safety. Once they reach the seat, you will have them back up until both of their legs feel the chair. Make sure the walker stays with them and they stay in the frame even at this point. They will also reach their arms back to the armrest, and then they will slowly lower themselves with control. Again, if a gait belt is on, this is where you would assist them, and if a gait belt is not present, you can assist at their hips. The final and highest level of mobility is assisted walking, and we do this with staff supervision. So by this point, the patient has completed the transfer safely, and we are progressing further. So we've confirmed they are stable in standing, and if a gait belt is available, it would have been on the patient at this time. You would, as the staff member, be positioning yourself slightly behind or on the side of the patient, and we are using the same cues that we did for the transfer. So we want to make sure they are standing tall with their body within the walker frame, and they are taking slow and controlled steps. Just like every other phase of mobility, we are still monitoring for dizziness, fatigue, shortness of breath, or instability. And just like every other phase, if the patient does present with one of those symptoms, we would stop, we would stabilize, and we would reassess. So that would mean likely having a chair nearby or an extra set of hands to allow the patient to be in a seated position for the highest level of safety. After you have completed your highest level of mobility with the patient in a safe manner, the patient needs to be left in a safe position. We do that with our setup and safety check. So if the patient is in the recliner or in the bed, you need to activate the alarm, and that is part of the Go Green initiative. It is required for all patients. We also recommend floating the patient's heels. That means that the pillow will be under the patient's calves and not under the heels so that there is no additional pressure at that point. If ordered, you would apply SCDs, and then when appropriate, you can place a pillow under each arm for more support. We also want to make sure all of their lines and tubes and drains are untangled and secured and in a position where they can be appropriately functioning. We would have the call bell in reach or in their lap, and all personal items within reach as well, so that the patient does not have any reason to try to stand without staff assistance. And we would also confirm that the lighting is appropriate for the time of day. This would be part of the delirium prevention. So if it's daytime and it is appropriate for the patient, we recommend having the blinds open and the lights on. A few things to consider. If the patient has wounds, especially on their bottom, you will need to reach out to wound care for specific guidelines and to make sure that their offloading recommendations are followed. We also want you to just double check and make sure that the patient is comfortable, they have everything within reach before leaving the room. And that is the conclusion of our presentation. There will be in-person trainings at a later time, and that will be communicated to you when it is coordinated. I did want to leave you with a final thought and goal for all of us to work together to be part of the solution. Mobility is such a huge part of patient care, but it can also feel overwhelming and new at times. And the therapy department wants you to know that we are here to support you in any way that we can. And we really look forward to taking this first step forward together. If you have any questions, your manager can direct them to us, or you can reach out to Ellen Clemens, Hannah Pendergrass, or myself directly. We really appreciate all of you and hope you have a great day.